Grab your stuff and get a seat. We're going to go ahead and get started here. It's really a pleasure and an honor to have our guest speaker here with us today. Dr. Sandra Kim is currently the co-director of the Inflammatory Bowel Disease Center and the Associate Professor of Pediatrics in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition at Children's Hospital in Pittsburgh. She received her undergraduate and medical degrees through the Interflex program at the University of Michigan. She completed her pediatric residency and pediatric GI fellowship training at Baylor College of Medicine and a research postdoctoral fellowship at the University of North Carolina under Balfour Sartor. Dr. Kim's clinical and research interests focus on pediatric inflammatory bowel disease, including adolescent transitioning and quality improvement in pediatric IBD. She also studies the impact of the gastrointestinal microbiota in IBD. She currently serves as a chairperson of the Government Affairs Advocacy Committee for the Crohn's Colitis Foundation. In addition, she chairs the Clinical Practice and Adolescent Training Committees, serves on the Physician Leadership Committee and Strategy Council for Improved Care Now, which we are also a member ourselves. As a reflection of her dedication to her patients and her profession, Dr. Kim was awarded the Rosenthal Award for Leadership in Patient Education and Advocacy by the Crohn's Colitis Foundation, not once in 2011, but twice, just this year, 2018. Suzanne Rosenthal is a co-founder of CCFA, and it's really a credit to her personality, and she is a well-respected member of our entire division nationally. It's a real treat to have her here. Dr. Kim.
Thanks. You know, anytime you hear those introductions, the first thing I say is my mother would say, well, you still need to eat 3 meals a day and toe the line, even though I'm almost 50. So I hope in this morning, and by the way, food is very appropriate because I am a GI doc, and if folks are a little tired and start dozing off, it won't offend me at all. I'm just happy that you guys are here. So I thought I'd take the time this morning to talk about a topic in an area of diseases, so inflammatory bowel diseases, which really has been the area of the focus of my career since my residency days at Texas Children's Hospital in Houston. And so I don't have any financial disclosures, but I do have the disclosure that I'm a first-time owner of an impossibly cute mini golden doodle who is also a rabid Michigan fan, and we were a little bit sad on Monday with the outcomes of the game, but I'll tell you, Villanova looked great. They deserve to win. So that having been said, so this morning I hope some of the things that we can cover in our time here, defining what inflammatory bowel diseases are, IBD, which is different from irritable bowel syndrome, talking about the idiopathogenesis, that's a good spelling bee word, and unique issues when we talk about the pediatric and adolescent patient population. And then I'm going to focus on nutritional therapies, which I think for a lot of folks probably are familiar with IBD. You all are probably familiar with a lot of the immunosuppressive medications we use, but I want to start talking about the role of nutrition as we start thinking about the treatment of children who live with IBD, and then what I sort of define as future directions for our discipline. So just a quick overview of IBD, and if, by the way, I know I'm going to go fairly quickly with a decent amount of slides, so feel free to interrupt me if you have any questions. So when we talk about inflammatory bowel diseases or IBD, we're talking about chronic inflammatory diseases that can involve the gastrointestinal tract. And when we talk about the classic symptoms, what we call that classic triad, abdominal pain, bloody stools, and diarrhea. Although I will say that while a lot of patients present this way, about 70 to 80%, there are some patients who don't have these symptoms, and I want you to sort of think about this as we talk about some of the topics today. So other things include weight loss and growth issues, fatigue, fevers of unknown origin. And I just want to show this slide to talk about the fact that even though IBD is managed by GI physicians, we really have to partner very closely with our colleagues because there are a lot of systemic issues, endocrine, rheumatologic, dermatologic, et cetera. And so really it's a collaborative process when we manage our children and teens who live with IBD. And so when we talk about Crohn's disease, which is one of the IBDs, Crohn's disease basically affects anywhere from mouth to the anus. When you look endoscopically, I'm a GI doc, so I've got to start with a few endoscopic pictures. What you'll see is what we call skip lesions, areas that are involved and areas that are not so much involved, more deep ulceration. When Certain sections are resected and we can look on the outside. You'll get what we call fat wrapping and cobblestoning. If you look under the microscope, the classic finding is what we call granulomas, although we don't always see that on biopsies, but that's sort of a classic finding. And even though the days of doing upper GIs has sort of gotten a little bit to the side as we do more CT and MR enterographies, one of the classic signs we used to say is that if you had more complicated disease where things strictured down, you could always see what we call a string sign there. So that's going through the terminal ileum, and you can see that there's narrowing. Ulcerative colitis, on the other hand, only involves the colon, although sometimes you can have what we call backwash ileitis. It's more of a continuous inflammatory process going distal to proximal. It's more submucosal. It has more of this superficial, almost very inflammatory but granular appearance. If you look under the microscope, you'll have sort of changes in those crypts. Again, going back to pathology, even though we don't look at slides, we still learn this at some point. And you can also see what we call crypt abscesses. So when we talk about IBD, it's one of those chronic inflammatory diseases, and one of the first questions I get from patients, so you've got a lot of smart people studying these diseases, so why isn't there a cure or a treatment? Unfortunately, it's not so straightforward. So when we talk about IBD, it's not just one thing. So we talk about genetic susceptibility. Genetics are important, but unlike a lot of diseases that are specifically inherited, with Crohn's disease, genetics is only a piece, and so just to give you an idea, back in the mid-2000s, one of the first seminal genes called NOD2 was discovered, and that was noted to be associated with patients who had a specific type of Crohn's disease. And since the mid-2000s, over 240 genes have been found to be at least associated, potentially causative, but we still need more data. So clearly, genes are one piece, but if you have 240, at least associated with it, it tells you that there's probably a little bit of heterogeneity. So with genetics, we've got the genetically susceptible individual. So then within that individual, there may be changes in the normal commensal or GI tract microbiota. And the thought is that if you have Crohn's or ulcerative colitis, that typically the balance between more the inflammatory versus the protective bacteria is skewed. But then what are other things that can lead you to develop IBD? So genetics, changes in the microbiota, but you have to think about the environmental triggers, and that's why a good part of my talk will focus on one of those environmental triggers, which is diet. And then if you have that sort of perfect storm of genetics, changes in the microbiota, the right or wrong environmental triggers, that leads to sort of that dysregulated and perpetuated inflammatory response that causes and sort of maintains the damage that we get in folks who have IBD, especially if disease is not under adequate control. And so we talk about genetics. We know that there is an impact, not just because of all those genes that have been found to be at least associated with folks who have IBD. There's usually an occurrence in families, anywhere from 15 to 25%. We find that often, at least folks who have Crohn's disease, that clinical pattern of disease is preserved within families. And the younger you are with onset of disease, and that's pretty much all of us. I mean, we take care of pediatric patients. There's a greater likelihood that there's a family history. And again, as I said, there have been genes associated with specific types of IBD. And, you know, it's interesting. So this is way back when I think probably at least half the people in this room were probably not even born, back in the Scandinavian countries where they were really able to look at the registries. They looked at twins who were both identical and fraternal and found that at least with Crohn's disease, there's about a 50% concordance versus ulcerative colitis, which was considerably less. So this highlights that genetics is important, but if it was the absolute, then you'd expect a higher concordance. So we talked about genes. The microbiome is a subject that's sort of near and dear to my heart. So when we talk about the microbiome, we think about bacteria, but really it's all those microbes that are sort of involved. It's just that we have the best knowledge of bacteria to date, although that's really improving. And one of the things that's been found is that you have distinctive microbiomes or collections of these different microorganisms at different body sites. And so this, the Nature Review paper is a little bit old, but it still gives you a nice overview of understanding what we say when we talk about distinct microbiomes in different parts of the body. And so with the gut specifically, because I am a GI doc, I still remember in medical school, I had a pathology professor who said that the colon is a social organism, meaning that we've got just a lot of microbes. So even way back when in the dark ages, when I was in medical school, we knew that that was important, and we've become better at understanding that. And so you can see over 100 trillion bacterial cells. The density is the highest in the colon. But what's even more important is the genome size of the microbiota. So the genetic impact of the microbiota in the GI tract is 150-fold greater than our human genetics itself. So really that's quite important. And so why has there been such an explosion in understanding the different microbiomes? You know, way back when, we used to take those Petri dishes, we'd streak them out, we'd grow bacteria. But, you know, in the past decade or so, with the ability to do high-throughput sequencing, combined with really, really sophisticated bioinformatics, we've been able to better define not only different components of the microbiota, but looking at concepts like microbial diversity to really understand sort of those unique changes within the microbiota in different sections. So why is bacteria important? So we've talked about genetics, we've talked about bacteria. There have been different studies that have suggested that you could possibly look at the changes in either the diversity of the bacteria in the intestinal tract or even increases in certain types of species that may correlate, if not with induction of disease, certainly correlate at least with disease activity. So this study that I'm showing you, it's a long study, but I'm going to give you a synopsis. So the results I'm going to show you are from a study that was a prospective study of children at the time of diagnosis of their Crohn's disease. So really, it's not quite like the Framingham study where you follow folks forward, but really this is an ongoing study where we took these kids when they were diagnosed, and we've been collecting data throughout time to see how they do clinically. But at the very beginning, data that was collected included biopsy samples, blood for immunology, sort of serology, genetics, and also looking at both mucosa as well as stool for bacteria. So there have been a lot of papers that have looked at it, but for this specific paper, what they looked at is the types of bacteria you saw sort of in the lumen, so basically in the stool, in patients who had IBD. And so a couple things that they found in these kids, that more of the protective types of bacteria seemed to be higher when patients were in remission, but more the inflammatory bacteria seemed to sort of bloom or increase when there were associated exacerbations of disease. And they found that rectal biopsies and looking at the adherent bacteria could be a strong disease predictor, sort of independent of where the patient's disease was. And we look at this because we like to understand how certain things work as we're trying to think of sort of that idiopathogenesis. We want to look at ways that we could possibly even have non-invasive biomarkers. So how can we predict if someone's going to do well or not? So again, more needs to be done. It's ongoing research, but just wanted to bring this up. So now let's think about, so we've talked about genetics, we've talked about bacteria. So what's the relationship between bacteria and diet and environmental triggers? And so I'm going to first show you this study. Kind of a busy slide, but I'm going to walk you through this. So this is not from kids with IBD, but rather healthy children from Burkina Faso. So those are the black bars. So that's in West Africa, versus EU stands for Europe. So these are Italian children. So totally healthy kids not having GI symptoms. And what the authors wanted to do was look at the composition of bacteria in otherwise healthy kids, really looking at the impact of diet. So the kids from Burkina Faso ate their typical diet, which is not processed, and the European diet, which is your typical westernized diet. And really the take-home messages that I want to show, in graph A, they measured short-chain fatty acids. So short-chain fatty acids are important because those are good nutrient sources for the colonocytes. And so you want a higher amount of short-chain fatty acids, and what they found is in the kids who ate a less processed diet from West Africa, you had higher levels of short-chain fatty acids. And then the graph in B just shows different types of enteric organisms, E. coli, Salmonella species, Shigella, et cetera. And again, the take-home message in these otherwise healthy kids is that the kids who were from Burkina Faso actually had lower levels of what we consider to be more inflammatory bacteria. So this makes you think that if even in healthy folks, your diet could impact things like your bacterial composition, things like short-chain fatty acids, what happens if you're already genetically predisposed to developing a chronic, lifelong inflammatory disease. And so I'm going to give you sort of an overview of different studies that have looked at the impact of diet and IBD development. So the first study I'm going to give you, this is from the National Nurses Study. This was done with our colleagues at Harvard, both the adult and the pediatric GI folks. But one of the things that they found in this study, when they looked at patients who had Crohn's disease and ulcerative colitis, that women who are in the highest quartile of prudent diet score. So what is a prudent diet score? So basically, it's looking at how healthy your diet is. And I'm sure you guys all have great prudent diet scores, so I'm not here, and I won't call on individual folks because I don't know you guys well. But what they found is when they were in the highest quartile, so the healthiest diet during high school, they had a significantly lower risk of developing Crohn's disease in the future, although ulcerative colitis risk did not change. And the biggest things that had the best correlations in terms of decreasing the risk were your fish intake and fiber, and I suspect it's probably grilled fish, not fried. The other thing that they found is that for Crohn's disease, your risk decreased by greater than 10% for every 10 grams of daily fiber intake. And then other studies have looked at not only fiber, but the impact of high fat, especially high saturated fats. And so some of the work I'm showing you, it's more in mouse models, but what we found is that in a high-fat diet, it can change or worsen your intestinal permeability, and there are sort of different mechanisms that have been postulated. So sort of one of the take-home messages is higher fiber, lower saturated fats, certainly what we advocate for everybody, could also have an impact on whether you develop IBD if you're already predisposed. Busy slide, but this is another elegant study that was done by our colleagues at the Children's Hospital of Philadelphia and Penn. And bottom line is what they did is they looked at kids with Crohn's disease, and you can see they had all the kids at baseline. They defined kids with Crohn's versus kids who are healthy with or without antibiotics. And then they looked and saw that there were certain sort of more inflammatory microbes that were increased. And then at the same time, then they broke it down to the kids with Crohn's disease. That's the antibiotic group. And then if you were on antibiotics on top of it, again, there was an increase whether you were or weren't on antibiotics with Crohn's disease for other reasons, not specifically related to the Crohn's disease. Again, increases in inflammatory sort of species. And then they looked at patients on diet and a specific type of diet called exclusive enteral nutrition, which I'm going to talk about for really the remainder of our talk. And again, using that as treatment, found that it actually decreased some of the more inflammatory type of species. And by the way, everything in the pink bar are the ones that we think about. And then they later on looked at the role of inflammation on the microbiota, adjusting for all of these different pieces. And so before we go into the impact of diet and dietary therapies, we've talked about IBD, we've talked about etiopathogenesis. Let's talk a little bit about children and why focusing on nutritional therapies is particularly crucial in the pediatric population. And I often show this slide because a lot of the talks I give are usually for adult groups, and so everybody just assumes that kids are small adults, and if that was the case, I would probably still be a child, although I am in pediatrics, barely at 4'11" right now. But I think the reason we say that is because we as pediatricians know that kids aren't adults, and we need to think about that on multiple levels, how we diagnose, how we treat, and looking at long-term effects of having a chronic illness. And so I want to highlight this slide because folks used to think that IBD really was in adults, and you may have kids that would rarely develop it. The reality is at least a quarter of all folks in this country, and we estimate that there are probably about 1 million to 1.5 million, although there are some papers that suggest it could be as high as 3 million. Out of that sort of patient population, about a quarter are diagnosed in childhood. And so this is a study that was done about a decade ago, and I suspect as new studies come out, we're going to find probably similar trends. This was done out in California through the Kaiser Permanente database, that the annual incidence for Crohn's disease and ulcerative colitis really had gone up significantly. And you can sort of see how that's been going up. And similar studies in Canada by the folks at University of Toronto, led by Eric Benchamal and Anne Griffiths, has shown similar trends, that we've really had a significant increase in incidence of IBD in children. And a group that has really increased are kids who have what we call very early onset. So the kids who are under 5 years of age and infantile, so kids who are infants. And so when we talk about pediatric IBD, you know, I already talked about some of the symptoms that, that patients with IBD have. And so there are a lot of similarities. So GI symptoms, the extraintestinal manifestations, but kids really bear a really even a heavier burden. The presentation is often much more severe in children. For instance, if you have ulcerative colitis, there's a higher incidence of more fulminant or pancolitic disease, meaning the whole colon is involved, not just sort of the distal part. In Crohn's disease, there are risks of surgery and development of what we call more complicated phenotypes that I'll talk about. And then really very early onset or infantile. So, you know, a lot of adults obviously worry about the cumulative effects of having a chronic illness. Well, imagine if you're a parent and you're told by your physicians that your 12-month-old or your 4-year-old will have this lifelong chronic illness that could really have an impact on their lives. So you can imagine, not only do you worry about severity, but sort of the life-term impacts. And so I think in pediatrics, unlike our adult colleagues, the other things we have to worry about, besides dealing with kids with more severe disease, is that we have to worry about growth. It's an obligation we have. Kids need to grow. They need to have appropriate skeletal development. And the psychosocial impact of having a chronic illness. And so this slide was done by a European group that looked at really the progression of disease and found, and again, busy slide, but the round sort of circles represent inflammatory disease. So that's typically what we see. But then when we talk about stricturing disease, that's when you get scarring down, or penetrating disease, that's when you develop things like fistulas. So you can obviously realize that that's sort of a progression that patients will often progress to fairly significant disease. So they start off as having more inflammatory disease, much less likely having sort of more of the less complicated forms, but you can see within 10 years that a lot of the kids, you can see sort of the decline of the inflammatory piece as more of these kids develop stricturing or penetrating, requiring surgical interventions. My former colleague at the University of North Carolina, Mike Kappelman, is really a well-known health services person, and what he did, he looked at patients and actually cost. And so while it's not all about cost, I think this should be a little bit telling. So, and this, by the way, was about 10 years ago, because I'm going to show you data a little bit later that talks about this. So 10 years ago, they thought that for the U.S. population, that the annual disease-attributable cost to IBD was over $6 billion. Sounds like a lot. About to get higher at my next slide. But overall patient cost, so this is how much cost an individual patient incurred because of their health care, that it was significantly higher in pediatric patients versus adult patients who have IBD. And you can see in the dark blue bars that if you have ulcerative colitis, the cost is almost twofold and a little bit higher in children and teens who have Crohn's. And so while this is not the only indicator for severe disease, this really tells you the impact the kids have. And so this sort of is a telling point. We see it in clinical practice, we see it financially, and it's also something to think about as pediatricians as we think about the impact on families. And so I'm just highlighting this growth failure piece as we talk about growth and nutrition. Because, you know, we talk about the classic presentation. So a lot of you are probably not going to go into GI, but I hope we can convince some folks to do so. And so, you know, it's usually pretty easy when you see someone with the classic presentation. You go, you know what, they're having abdominal pain, diarrhea, weight loss. We can't really attribute this to just a stomach bug. This has been going on for months. But sometimes folks won't present with these symptoms. And these are just some of the things that I want to highlight, that some folks can just present with growth failure or some of these other things. And I bring this up because growth issues are a huge problem in pediatric IBD, especially in patients who have Crohn's disease. But it's not just pre-diagnosis. It can continue post-diagnosis. And in fact, depending on when you diagnose a child and when you start therapies, if you can't catch them before they start their growth spurts, they may already have sort of impaired sort of what would have been predicted sort of adult heights. And so several studies throughout the years in both Europe and the U.S. have looked at height percentiles and found that a good percentage of patients have had what we would have calculated to be their sort of their mid-parental height was compromised because of having Crohn's disease or ulcerative colitis. And so it's not just the overall height percentiles that they would reach, but that ongoing sort of height velocity. So when we talk about growth issues, we say that the growth window is crucial. So diagnosis is crucial, starting treatment is crucial, starting the right nutritional supplementation is crucial, and that we not only have to look at poor growth as a possible sign of early IBD, especially with Crohn's disease, but it's also a good marker for disease activity. So I want to sort of tell you what my thoughts are, or what goals of treatment need to be. So we need to rapidly get someone's disease under control, but we have to maintain the remission. It's not just about clinical symptoms, but it's also actually healing the lining of the GI tract. We also have to control and relieve symptoms, and those are not always the same thing, because someone may say that they don't have symptoms, but we find that they have active disease. So we have to do both. At the same time, you can heal someone's mucosa, but if they're still having symptoms, you need to figure out why. We have to prevent complications of the disease. We've already said that, especially with Crohn's disease, things can progress, but also the complications of the medications and treatments themselves. We have to promote normal growth and development. That's our obligation as pediatricians, not just as a GI doctor. Minimize steroids whenever possible, and that's what we try to do with all of our interventions. Maximize treatment compliance, meaning just because we have great drugs, if they are way too costly or if you have to take too many of them, you can't maintain it. So we need to really think about all those things, and then improve the quality of life and alter the natural history of the disease as favorably as possible. And I bring this up because remember that previous slide I showed you said that the attributable cost to IBD in the U.S. was over $6 billion. More recent studies calculate that it's probably upwards of $30 billion or greater. And I bring this up because we have improved how we can care for children who have IBD. We have great medications that were just in the pipeline when I was in residency training, and one is something called infliximab, which is one of those IV medications. It's what we call a biologic. It inhibits anti-TNF and has really been shown to heal the mucosa, improve growth, and really change how we treat kids with moderate to severe inflammatory bowel disease. But the cost can be prohibitive. And if you look at this breakdown, what they found is in the subgroup of patients that had costs greater than $45,000 a year, probably 2/3 of the costs were from some of the medications we use. So I'm not here to advocate that we don't use them, but as we think about it, this made me go back and say, so as a doctor, so I know I can't change the genetics. I know there may be ways that we can change the microbiota. What can we do to look at the environment so that we can possibly either alter how the microbiota sort of balances out, so that we can possibly, could we alter the course of disease, that even if we have to use some of these medications, that we could also do other things to improve the quality of lives of our children, augment their therapies, and try to figure out a better way to sort of contain the cost. And so diet is a big thing. So I've alluded to what we call enteral therapy. I'm going to start saying EN, but I know in medicine we use too many abbreviations, and we could probably write an entire H&P using abbreviations only without any full words. So I'm going to try my best not to use too many. But when I say enteral therapy or EN, that just refers to the liquid formulas that we use. And in this scenario, it's only for Crohn's disease. It's not been found to be effective in ulcerative colitis. And then when we say EEN versus EN, it's exclusive enteral nutrition, where we use enteral nutrition as a sole source of nutrition to induce remission and possibly even maintain remission in Crohn's disease. Partial enteral nutrition, or PEN, is when we use enteral nutrition, so the formulas, as a majority or portion of the nutrition in addition to regular foods to possibly induce remission, maintain remission, or improve nutritional status. And I say this as we talk about some of the data that I'm about to present, that moving forward, EN, and PN are sort of the things that I'm going to refer to. So I'm going to first give you a case study before we talk a little bit about enteral nutrition, because I'm going to stop here. So how many of you have actually treated or seen a patient treated with enteral nutrition? Good. So I'm already, this will make this a lot easier, but I'm going to give you a case study here. So I had a 10-year-old patient, 7-month history of significant weight loss, non-bloody diarrhea, unexplained fevers to 102, intermittent emesis, abdominal cramping. And it was interesting is the family treated his symptoms by doing these 2 to 4 day liquid diet cycles with regular formula and then lighter foods and regular diet. And they'd say he'd get actually better by doing it, but then by the time they got to regular diet, he got worse. So when he presented to me, he was at the 8th percentile for weight, 53rd percentile for height with a BMI of only 13.6, was anemic and had an elevated SED rate, and negative infectious stool studies. And so when we did the EGD and colonoscopy, found ulcerations throughout the stomach and colon, and we diagnosed him with inflammatory chronic Crohn's disease with upper GI tract involvement. And then we did an MR enterography because, again, with scopes, you can only reach so far from above and so far from below. Wanted to look at his small bowel to see if there's involvement, and we found that there was some small intestinal thickening in the jejunum and the ileum, but no narrowing or dilation. So, again, inflammatory disease, not stricturing, not penetrating. So I had a long discussion with the family. We talked about, what it meant to have Crohn's disease, what our goals of therapy were, what we looked at for both induction and maintenance. And after we discussed the risks and benefits for different medical therapies, the family initially chose to do enteral therapy because they were really worried about sort of the potential side effects that you could get from immunosuppressive therapies. And so we picked a 1.5 kcal per ounce formula. We didn't do quite 100%. Just because research has shown that even if you do 90-10, it's still pretty effective. And if you can imagine, we talk about effectiveness of therapies, but we also talk about adherence. And if you can do 90-10, we find that we can get a little bit more adherence. And so we worked him up to getting to 90% of his recommended daily allowance with the formula, 10% with regular diet, and found within a week he had decreased stools and his weight had increased almost a kilo. He stopped having fevers and his abdominal pain was gone, and that he had really done quite well within 2 weeks. And the family said, we're going to do enteral therapy for 12 weeks, but we don't think we're going to be able to maintain this as maintenance, so we will use methotrexate for maintenance therapy. So then I followed up with him within a month. No GI symptoms whatsoever, no fevers, gained 2 kilos, and really did not have any active disease. So let's look at the research in enteral therapy in Crohn's disease. And so we find that it's effective in children and adults, although a little bit more effective in kids and adults, anywhere from 50 to 75%. The 50% figure is probably more for adults, 75 to 80% for children and teens. And when you do a head-to-head comparison, when you look at enteral nutritional therapies versus corticosteroids, which has been sort of the traditional mainstay for induction, looking at multiple prospective randomized clinical trials, most of them in Europe and in Canada, we found it was found to that EN had better remission rates. It actually healed the lining of the GI tract or the mucosa, which is an important part of deep remission, and had a positive effect on growth. And so the conclusion that we have had as a pediatric GI community is that this probably is a much more effective way, if you can do it, than steroids, and that overall it is more effective in children than adults. And so when you think about side effects of medications and you talk to families about side effects and adverse events, there really aren't that many with enteral nutrition. So it's well tolerated, you're not suppressing the immune system. There are some possible GI side effects with nausea, looser stools, flatulence. So when we start someone on it, we'll work them up a little bit. And if you do have a severely malnourished patient, you do have to worry about refeeding syndrome. And in these patients, we will bring the patients in and monitor closely. And the other situation is if a patient is that severely malnourished, they may have more severe disease, and these may be the patients who ultimately may not have this as a primary therapy, but something to think about. So unlike all of us in the U.S., where we've been adopting this much more in the past several years, the Europeans and Canadians have been doing this for, I think, decades now. And so, in fact, the European Crohn's and Colitis Organization and the Pediatric GI Societies had specific guidelines that they published a few years ago. And so they did evidence-based review of all the data. They looked at treatment algorithms and stated very clearly that exclusive enteral nutrition should be the first choice for induction therapy over steroids, especially in children who had not finished growth where they have Crohn's. And they even outlined what the predictors would be for poor outcomes. So severe disease, so more of the complicated forms, fistulas, stricturing, severe growth failure, and panenteric disease, meaning that a huge chunk of the intestinal tract is involved. So one question that always comes up, from folks, from dietitians, should we use more of a broken down or elemental formula or just a regular modular polymeric formula? And Mary Zackos from Toronto did a nice Cochrane review, and the bottom line is that they found that there was no significant difference. And this is important for a couple reasons. One, polymeric formulas are less expensive and more accessible than elemental or broken down formulas. And second, we really try, at least in the institutions that I've been at, to encourage people to drink it rather than doing it through a nasogastric tube, although you can certainly do that. And if you try drinking a really broken down formula, which is kind of like taking filet mignon, breaking it down to the basic amino acid components and saying enjoy. I don't actually eat meat, but I'm assuming filet mignon tastes better than amino acid components, versus giving them the filet mignon itself. You get the idea. Palatability is important, especially for compliance. And so lots of studies, but this is a study that I found that was actually a prospective study looking at induction using polymeric formula versus steroids in patients with pediatric Crohn's disease, newly diagnosed, half and half. They used either polymeric formula for exclusive enteral nutrition or steroids, and at 10 weeks, they found that both clinical remission, so what was reported, disease activity index, that there was a significant improvement in patients who had enteral nutrition versus steroids, so 80% versus 2/3. And even more important is that concept of deep remission. So it's not just about symptoms, but how does that mucosa look? Is it healed? And there was a significant difference with enteral nutrition. 3/4 had mucosal healing versus only 1/3 with steroids. So we say induction. So with families, 8 to 12 weeks, usually the pep talk, we really sell them on this, like you can do it. So what about maintenance? So imagine sort of staying on this longer term. And so there was a nice study actually from Japan where they looked at patients, adult patients, who were already in remission, and then they basically put them in two groups. One group had enteral nutrition and a low-fat, healthy Japanese diet, which I suspect is a little bit different than the American diet, but I'm not here to make judgments right now, maybe a little bit later, versus the other group who just did the healthy low-fat diet. So what they found is when they followed these patients up in a year, that a significant proportion of the patients who had been in remission and then went on the diet, on enteral nutrition, did much better. They did better clinically, but when they looked at the mucosa again, they had significantly lower endoscopic inflammation scores. We have ways of scoring. And they looked at the mucosal biopsies, and they measured pro-inflammatory cytokines like TNF, IL-6, IL-1 beta. And so that showed that it wasn't just about symptoms, it was also about true healing and gave us an idea of possible mechanisms. And finally, so we talk about induction, we talk about maintenance. So how does it affect folks even if they can't stay on enteral therapy? So some of our colleagues down in Australia did a retrospective study looking at all their patients that had good 2-year follow-up, almost 100 patients who had had induction therapy with exclusive enteral nutrition, comparing them to those who had more the traditional steroids and had, as a maintenance medication, thiopurine, which would be 6-mercaptopurine, azathioprine. So a couple take-home messages in this retrospective review that they did is that, one, there were better overall clinical outcomes in the patients who had started off having induction with enteral nutrition versus steroids. So in that 2-year follow-up, they had less growth failure, they had decreased overall steroid dependence for future, and most importantly, the patients who had to have sort of escalation of therapies to anti-TNF like infliximab, they had better responses if they had started off in life, the life of their disease with EN as induction versus steroids. So our colleagues at the Children's Hospital of Philadelphia probably have the largest cohort of patients and really were the ones that were sort of at the forefront, at least here in the U.S., and really using this actively as a part of the treatment sort of armamentarium. And so Gupta and colleagues working with Bob Baldessano as a senior author looked at their patients over a several-year time period that had been treated with enteral nutrition. And a couple things they found is that there was a significant decrease after months of being on enteral nutrition with their disease activity scores. Their weights improved. They also found that the SUD rates came down significantly, and their albumin levels improved as well. So we talk about enteral nutrition. We know it's better than steroids, but how does it go head-to-head in sort of the big gun of therapies that we use in IBD, so namely anti-TNF therapies like infliximab or adalimumab. And so this is a prospective study. So they looked at over 90 patients, and they classified these kids into those who were on anti-TNF therapies, exclusive enteral nutrition, or partial enteral nutrition, meaning that they had at least 50 to 60% of their calories as enteral nutrition, and the rest they could eat what they wanted. And so when you look at the parameters of clinical remission, so they looked at disease activity index scores. So interestingly, similar between the patients who received anti-TNF versus exclusive enteral nutrition, still pretty decent in those who had partial enteral nutrition, but less than the other two groups. They also looked at calprotectin. So for those of you who are not familiar with what a calprotectin is, but I suspect you guys are, it's a good stool marker for inflammation. And they found that the biggest decreases in calprotectin were in the patients who had anti-TNF, but still a pretty good percentage in those who had exclusive enteral nutrition, less so in those who only had partial enteral nutrition. But the other piece was the quality of life that we always talk about. So, we've talked a lot about, controlling disease, inducing mucosal remission, but we still have to talk about, the quality of life that we're giving these kids. And so they found that certainly in the realm of body image, it was the best with EN, but in the emotional domain, it was the best with anti-TNF. And so when you look at that, you do wonder that for all the things that are positive about EN, it isn't easy to do, and that may have an impact on emotional. So final piece, so we've talked about induction, we've talked about maintenance, we've looked at sort of at least an initial head-to-head comparison between some of our medications. What are other ways that we can use EN? And this should be of interest to our surgery colleagues. So there's been a lot of work that's looked at sort of the impact of using exclusive enteral nutrition to see if you can improve surgical outcomes and decrease morbidity and mortality. So this study looked at 80 patients, or adults, that were about to undergo resection for strictures related to their Crohn's disease. One thing, for different reasons, and this was not so clear, patients could not get any other treatments preoperatively for 3 months, which is a little bit different from what we do, but this is what they did in the study. And so half the patients got EN, the other half did not. And so postoperatively, that they found that those who had received enteral nutrition had significantly decreased infectious and non-infectious complications, and that you had initial decrease in recurrence endoscopically, although clinical recurrence rates were similar. So again, a small study, it gives you an idea of different ways that we can use enteral nutrition. So how does it work? It's sort of a million-dollar question. We know how a lot of our medications work. So what is the specific mechanism? And so folks have really focused on the microbiota, but what's interesting is it may not be exactly as effective in making changes in the microbiota as we think, although more research needs to be done. And so if you look at least recent studies over the past few years, they find that there's not an impact on the overall diversity of microbiota, but there may be changes in specific species that are associated with increased disease activity. So while we think that exclusive enteral nutrition could have an impact on the microbiota as one of the ways it works, we really need to do additional studies to look at associative and causative roles. Another way, and I kind of alluded to sort of cytokines before, this is a study by Dirk Haller's group in Germany, and they looked at cytokines, from mucosal biopsy samples, and they quantified cytokines. And sort of the take-home message is that one of the ways that EN could help is that it actually upregulates some of the protective cytokines and downregulates some of the inflammatory cytokines. So it's just something to think about. And I actually want to emphasize, highlight sort of if you look at both A and B, you can see how TNF goes down. And considering that one of our mainstays of therapy are anti-TNF, it's certainly something that we need to think about a little bit more. So maybe I've sold you on the fact that really exclusive enteral nutrition works, but there is what works clinically and what works in theory, but how easy is it to do? And so this was a survey from Scotland where they looked at patients who had successfully completed enteral nutrition therapy for their kids with Crohn's disease. And so they asked both the kids and the parents, which is always a good idea. And so overall, so black bars are positive, the hashed negative, the gray neutral. Overall, I think everybody was pretty positive on using additional enteral nutritional therapy if they needed it. But they also really expressed a strong preference for SFD or solid food diet alternatives rather than exclusive enteral nutrition if that was an option. So there's been a lot in the lay press and more in our medical sort of world looking at specific diets that could be effective to treat inflammatory bowel disease. One is something called the specific carbohydrate diet, or SCD, and the other is something called the Crohn's disease elimination diet that's gained a little bit more traction recently. So there's not a lot yet, but I'm going to show you a little bit of data in the pediatric realm from our colleagues in Seattle who have really been at the forefront of utilizing specific carbohydrate diet, not only in clinical practice and having the resources, but looking at things from a research and QI or quality improvement perspective. And so they published this recently. So they looked at patients with both Crohn's disease, so it's on the top, and ulcerative colitis. And so a couple of things they looked at. So PCDAI, by the way, and I apologize, that stands for Peds Crohn's Disease Activity Index. So that's just a clinical disease activity index score that we calculate. So they looked at patients with Crohn's disease and you can see that at the inception of, or right before specific carbohydrate diet was initiated, they had active disease, they had mildly elevated inflammatory markers with a SED rate and CRP. Cytocrits were a little bit decreased. Calprotectin was definitely elevated, so typically we like to say that it should be like in the low 100s. It depends on sort of scales you use, but it's definitely up. Vitamin D level was okay, BMI was okay. They followed them out 6 to 12 months later and found that the activity index scores got better, as you can see. Inflammatory markers improved. Hematocrit was improved as well. Albumin was about the same. Vitamin D was the same. BMI, it came down a little bit, but I wonder if it's about the restrictive nature of the diet to a certain extent. Same thing with ulcerative colitis. Again, disease activity index scores were elevated. SED rate was a little bit up. The other parameters didn't look too bad, but you can find where it really improved was the inflammatory markers and the disease activity index scores. So their sort of take-home points were that you did have improvement in about at least half the patients, and this could be a potential component of a therapeutic regimen. But remember we talked about it's not just about the clinical symptoms, it's also about healing the lining of the GI tract. And this paper just came out recently in sort of late fall of 2017. So they looked at their patients at least with Crohn's disease. So these are folks who clinically felt that they were doing better. Their labs looked good, CRPs were normalized, albumin was normal, clinical symptom scores were great, but when they scoped them, the majority did not have any mucosal healing. So this is where we want symptoms to get better, but we also want to heal the mucosa. So I think more needs to be done as we look at the efficacy of specific carbohydrate diet in Crohn's and UC. So another type of diet that's been proposed is something called the Crohn's disease elimination diet, which is similar to the specific carbohydrate diet, that it's pretty restrictive, it's a little bit more flexible, but more importantly, our colleagues in Israel who studied this don't do this sort of on its own. They really combine it with partial enteral nutrition. So remember we showed you some of the data that partial enteral nutrition works, but it doesn't work quite as well as exclusive or anti-TNF from the CHOP data. But what if we could have a specific defined diet and combine it with partial enteral nutrition? Could that help compliance, allows folks to have more solid foods, and could it still be effective? And so this initial study a few years ago looked at patients at week 0 and 3 months afterwards. And the bottom line is the HBI stands for Harvey-Bradshaw Index score, which is another clinical disease activity score, that had improved. They also looked at the PCDAI. That also improved as well. Inflammatory markers came down. Hemoglobin started improving, although that wasn't so statistically significant, and albumin had also improved. And more recently, they also looked at its role in patients who actually have anti-TNF therapies failed them, meaning we've already gone to the big guns, like infliximab or adalimumab, they're not working, and that's when, as GI doctors, we're really in a really sort of major point of almost sort of medical sort of conundrum, because if our strongest medications are not working, what do we do? So they actually took patients who were not responding to these stronger medications and found that they could actually get a decent percentage of these patients into remission using either the Crohn's disease elimination diet with partial enteral nutrition, even on its own, or making modifications in exclusive enteral nutrition. So again, not perfect, but this gives us yet another use. So in summary, and some of the take-home points, impact of diet, clearly multifactorial, but it's important in IBD. There may be different mechanisms. Hopefully, some of you guys, if you're interested in translational or basic science research, may be working with some of the folks here at the Research Institute to look at these questions and look at not only sort of associative, but causative. We know that enteral therapy is effective as both induction and maintenance in pediatric Crohn's disease, and that specific defined diets can be effective, but more research is needed. So where are future directions for our peds GI discipline? I think we need larger scale studies looking at elimination diets, plus minus the usage of enteral nutrition with that. There are different basic and translational research questions we can ask, delineating the specific protective and inflammatory components of the diets themselves, i.e. food additives, because there is good preliminary research that shows that certain food additives, like emulsifiers, can actually lead to inflammation or potentiate inflammation. And healthcare delivery, because, as for the residents in this room, we hope when you finish a residency program, we give you the building blocks to have the right clinical tools. We hope that we give you more knowledge than you started with. We also hope that you teach us something as a faculty. But at the same time, when you go out there, we're going to give you the tools, but you have to think about how easily can you implement treatments and what can you do to make sure that your patients get the appropriate access, but at the same time can afford it. So I want to thank you guys for listening to me talk about IBD diet, a little bit of the microbiome in 55 minutes or less this early in the morning. So.
Going over here. Hang on one second. Sandra, this is a beautiful speech. Congratulations. By the way, I'm Dario, and I'll meet you later.
Yes.
So I have a comment
Sure.
and a question. The comment is regarding the microbiome.
Mm-hmm.
I know everyone is enthusiastic, is embracing the microbiome, etc. I say let's be very, very careful because we really don't know whether it matters at all in the etiology and pathogenesis of the disease. Whatever we see could simply be the result of the adaptation of the bacteria to a different situation. They just want to survive. And again, we don't know whether changing it might actually impact on the disease. I think we need some hard evidence before we say, well, let's focus on the microbiome because that's the cause of the disease. That's a comment. The question is regarding the differences between the adult and the pediatric IBD. Of course, you have heard this question many times, and we have no answers. So the question is, are they the same diseases, really? Because, as you know, one of the main hypotheses on why the incidence of adult IBD is increasing is the hygiene hypothesis, and there is very strong basic science research supporting that. So the children are not exposed to bacteria because we live in a cleaner environment, and because of that they accumulate natural killer cells which essentially have no tolerance for the bacteria when the children grow up. Now, that's hard, to extend to the very young population developing IBD. Because if you have IBD at 10, well, chances are that you might have had it since birth, because IBD is silent probably for 10 years in adults. And so if it's the same in children, it means they have IBD since they are born. So, that's one thing that always, puzzled me. Plus, there are many other differences, regarding the disease type, the response to biologics, etc. So the question is there any study, any genealogic study done in these children just to see whether by chance what we see is an amplification and enhancement of the genetic component during generations? So in other words, is there any study that has checked very carefully the family history of IBD in these children for generations and checked whether what we're seeing is, as I said, an amplification of the genetic component, which will make it essentially the same disease as in adult, as the adult disease, or this has never been done?
That hasn't been done. I will say that, in pediatrics, so some of the people that really look at genetics, like Subra Kugathasan at Emory, certainly we are trying to not only, I don't know, like going back in generations, maybe a little bit tough, but certainly looking not just at genetics in children with IBD, but also looking at sort of ethnic or racial differences. So I think there's just a couple things to think about that. Thank you for the comments. Microbiome, I think that's only a piece of it. I think we need to understand it. I don't think that's the answer. I used to think that was the answer, at least when I had grants supporting that, but now that I don't, I'll just say that as full disclaimer. I wrote this grant, said, yep, I think it's adherent invasive E. coli, but that's a totally different thing. But no, so even if we don't look back, I think the problem with genes to look back at generations, when we have over 240 genes, and are they linked? Are they causative? I always say that when we do these genome-wide association studies, and by the way, if anybody's a geneticist, I'm not, so you guys can ding me later. So it's kind of like when we do these GWAS studies and say there are 240 genes. Is it just associative, or is it truly causative? And what I mean by that is saying that if you get a bunch of people standing around and you find that half the people are basketball fanatics, for instance, is it because you just happen to be hanging out with folks who have it, or is that hardwired in? So that having been said, I do think that maybe it's not 10 years. There have been studies that have shown that at least in children that there is a lag of time to being diagnosed, probably at least a year or so when you look back at symptomatology. So while it may not be 10, I think with kids, the disease is different because, again, with all those 240-plus genes, certainly some of them may at least have a causative role. I suspect that the types of genes that are more associated with infantile versus early onset versus more later onset are probably sort of different sets of genes. We're finding that. And then I think, too, this is where I think I will have to say that this is why we know genes aren't everything. That's where the environment is important. And we know that even looking at different ethnic groups, there are different genes and gene sort of, mutations that we are more associated with certain ethnic groups or not. So the answer, no long-term, no sort of looking back ancestrally, but I think there are a lot of studies that are looking at specifically the pediatric population. So, yes.
So, Dr. Kim, thank you for a wonderful experience. That really was very informative. And I'm a hematologist, so I'm going to ask a question concerning the cellular component. So I know that there's lots of studies about cytokines. There's lots of studies looking at the microbiome. But has anybody really looked at what the cellular component of the inflammatory response is over the course of disease, and specifically in those patients who fail anti-TNF?
Yeah, so I think looking at sort of the changes of the types of cells that are developed that are sort of more prominent. So people are looking at that, and certainly it's a little bit tougher in human disease per se, but we do have different animal knockout models that can look at mutations in different parts of the components of both the adaptive and innate immune system. So we can look at mouse models that knock specific sort of lines out so that we can have mutations in specific immune cells, not just looking at the cytokines themselves. Because, again, this is why I think it's important. And I think as a clinician, I'm going to just tell you personally why I focused on IBD for the past 20-plus years. So when I was a first-year fellow, I saw a young woman who almost died because her Crohn's disease was diagnosed as a bad eating disorder. And I watched her sit in the PICU for a month as she was dealing with bowel perf and looking at all that, how long it took for her to get diagnosed, and then watching all the frustrations of getting the right treatments. And so that's when I said that, you know, we need to stop, we need to find a better way. So that having been said, we have these great medications like infliximab, New England Journal of Medicine articles, 1997. This was going to be great. It's an anti-TNF, but it doesn't work in everybody. And now we have all these biologics. So for all the medical students here, there's a reason you guys took immunology and memorized all the cytokines. It wasn't just to sit there and torture you for the first part of the boards. And so you're like, this is cool, great. So we've discovered all these cytokines, and these are cytokines that are produced by specific cell lines. So why is it that if we think we understand what causes inflammation, you can block it, that it's not still sort of getting disease into remission? And that tells me that everybody's a little bit different in those effects. And so that's why I think we have to have a better understanding, not only of the immune cells, not just of the microbiota. I partially agree with you. I think there's still a role, but how is that sort of interplay with the microbiota and sort of the immune responses that we get? Because that's how we really need to sort of think moving forward when we deal with IBDs, because it's not going to be one treatment and one cure. How do we actually personalize or target medicine? So.
All right. Oh.
Yeah.
All right. You get the last question.
So, thank you for a wonderful lecture, Dr. Kim. So I'm one adult IBD person, and to be honest, I've never really considered EN in my patients, but you provide a lot of great evidence for EN.
And actually, I have a whole slide set just on that. I realized I only had a few, so I can give you information too afterwards.
So I'm wondering about the practicality of starting patients on EN. So is that something that's been adopted or covered by their insurance, and what's the practicality of starting someone?
That was my last line on financial. Absolutely. So the cost is the most prohibitive. If you cost it out, we're talking hundreds of dollars. One bottle, and I'm not going to use proprietary names, of your name brand modular formula is a few dollars. So if you are an adult male, you roughly need 6 to 7 a day to get to your 90% of your RDA. Start doing the math very quickly. What we're trying to do on a national level is there's actually medical foods legislation for all of you advocacy folks, AAP, PGI Society, and in fact, that's one of our main pieces of legislation through my work with the Crohn's and Colitis Foundation is medical foods legislation. Because I think talking to the insurance companies is mandatory. So it's interesting, and this will probably be published at some point. So when they ask medical directors about nutritional therapy, because they're the ones that reject or don't reject, comments were like, well, if they have a mouth and they can eat food, why do you need this? And so this is where data like this is going to be crucial. So in the meantime, though, one of my former dietitians from my previous institution actually commented, she did the calculations. So if you do enteral therapy and you cut out the number of groceries that you buy, it's not going to make as much of a difference, and it's a heck of a lot less expensive than a lot of the copays for medications. I'm not saying that that's right or wrong, but still that's something to think about. The other question you should sort of ask is, how do you convince folks to do this? So the old way used to be the nasogastric tube, but we really want to normalize our kids' lives. Walking around with the nasogastric tube, some of them they wanted, okay. So as a group, our PGI group, we all did enteral therapy. Some people lasted a week. And so you learn a lot of tricks, and it's how you tell people how you do it. So, you know, ice cube trays, freeze, et cetera, lots of ways. But I think when you think about it in this way, so if you had a therapy that had no side effects, that would give you the nutrition you needed, you wouldn't have to do monitoring labs. You wouldn't have to get used to doing some of this. Could you do it? And I think, and that's how I pose it to families. Because if you go, oh my gosh, this is going to be really tough, but I just heard someone say that this works, so let's try it, you're not going to sell. So I think you need to do it first, though. If you're going to ask your patients to do something, you need to do it first. You come up with it. No, because I think that makes you the best way to do that. And one of my fellows right now is actually doing a project on how we can educate providers to then better educate the patients and using sort of survey-based design to come up with the best sort of educational tools and modalities. But that's why I think coming up with the right dietary interventions in combination with EN is really going to be important too. Because, you know, for a lot of the kids, they'll say, well, do it, but I don't want to look abnormal. So if we can find a way that they do the nutritional therapy, but when they're at school, they can have that modular meal that still looks like a regular meal, so be it. So.
Okay. Thank you very much.
Thank you.
All right, for this.